Good afternoon and welcome. My name is Tim Poe. I'm the Director of Telehealth with the UNC Cancer Network. Thank you for being here with us. July 28th, 2017, for our Community Lunch and Learn Lecture on Cancer series. A few preliminaries before we get started. If you need to reach us for any reason, you can find us via email at unccn@unc.edu. You can call or text us anytime. Monday through Friday with questions, including right now if there are any technical problems, and that's 919-445-1000. We'll be using Poll Everywhere in just a minute, both for an introductory poll and then later on in the discussion for questions and answers. You can check us out on the web at unccn.org. You'll also find us on Facebook, on Twitter, on YouTube. All right. I want to go ahead and get started by talking about our poll. If you would like to participate, we would love to have you do so. This is anonymous, so take a risk. Go ahead and try this out, and we'll find out the answer shortly. So the question is, men have a 1 in, and then what is that number, lifetime risk of developing prostate cancer. So what you need to do to join Poll Everywhere is first text the letters UNCCN to the number 22333. So you'll make a new text to the number 22333 with the letters UNCCN. You do that one time, that joins you to the poll. You can go ahead and answer this question, and then when you have questions at the end of the lecture, you can go ahead and text those. You only need to join once, and then we'll see your questions up on the screen, and our guest will be able to answer those. We hope that you'll be thinking about questions throughout the presentation. Go ahead and compile those, and then we'll look forward to answering those at the end. So again, what the question is, men have a 1 in something lifetime risk of developing prostate cancer. If you think that's a 1 in 5, you'd go ahead and submit A. If you think that's a 1 in 7, go ahead and submit B. If you think that's a 1 in 9, C, or 10, D. And again, 5 is A, 7 is B, 9 is C, or 10 is D. So you can share A, B, C, or D, and then we'll look in real time and see what you came up with in just a moment. All right. Our presenter today is Mary W. Dunn, RN, MSN, OCN, and NPC. Mary is a nurse practitioner in the Department of Urology at UNC Hospitals. Mary joined the UNC Urology Group in 2010 and has served as adjunct faculty for the UNC School of Nursing since 2011. Mary works in a multidisciplinary NP role, providing care to urology and medical oncology patients with GU malignancies. Mary received her Bachelor's of Science in Nursing from the University of Virginia. She completed her Master's of Science in Nursing at Duke University. And so, Mary, welcome. We're so glad to have you here today. Thanks for being with us.
Thanks for having me again.
All right. Well, let's take a look. We've got a 1 in 7. We'll wait just another minute for any more poll answers to come in. While we're waiting, let me ask you, urology oncology, what led you to that career?
A lot of people ask me that question because it's such a specialized field. Yeah. I was fortunate enough when I graduated from Duke to interview for this position, and I immediately knew that it was the right place for me because of the people that I was going to work with. I have phenomenal colleagues in both urology and medical oncology, and it's been the career decision for me, and I get to work with phenomenal patients and caregivers as well.
Great. Well, people make all the difference.
That's
so
right.
Thank you. We're certainly fortunate that you chose this.
Thank you.
Well, it looks like we're hanging in at 1 out of 7 for everyone who's answered the poll thus far. Do you want to give the answer away now, or do you wait until your presentation?
We could sneak in that you guys are really smart.
Okay, good to hear. All right, we always have a great audience. We're thankful to all of you for being here with us today, and without further ado, I'm going to go ahead and pass the equipment over to Mary. Prostate cancer, what to expect along the way. So thank you so much.
Thank you. Well, good afternoon. It certainly is a pleasure to be with you all this afternoon. Prostate cancer is a big topic, and there's a lot to cover in a relatively short amount of time. This is my first time giving one of these talks to a general kind of lay population, so I hope that you find the information that I provide to you this afternoon helpful. If there are any patients or caregivers in the audience, it sure is an honor to be with you all today. And just a caveat that everyone's kind of experience and journey along the way in their prostate cancer treatment is different. So a lot of what I'm going to talk about are generalizations. So let's get started. So these are just some objectives, just some major bullet points that I'm hoping to get covered here during our time together. So what is prostate cancer? So cancer is, and very basically, the growth of abnormal cells, and prostate cancer starts in the cells of the prostate. So you can see here, and I'll have another picture pop up shortly, but this is the bladder, and the bladder is where the urine sits before you're ready to void it out. And right under here, sits below the bladder, is the prostate gland. Through the prostate runs the urethra, which is the tube where the urine comes out when you're ready to void, and only men have prostates. So what is the prostate? I'm sure that you've heard that the prostate should be about the size of a walnut, and I hope that that is an actual picture of a walnut. It's a gland, and it's a muscular organ that lies deep in the pelvis, in the front of the rectum and under the bladder, and it's part of the reproductive system. So basically the prostate, what it does, it helps make the semen that comes out during ejaculation. So this is just kind of another side picture so you can see bladder here and prostate here. And when we do prostate exams, the finger goes into the rectum and we can feel the back part of the prostate. So how common is prostate cancer? Well, generally it's very, very common. So it is the most commonly diagnosed cancer in men other than skin cancers. And there are upwards of 3 million men living with prostate cancer in the United States. Men have a 1 in 7 lifetime risk of being diagnosed with prostate cancer. It's the third leading cause of prostate cancer death, excuse me. This year, there's an estimated 161,000 new cases that will be diagnosed, and about 27,000 men will die from prostate cancer this year. So these are just some graphs that I like to show. What this graph shows is basically that the vast majority of prostate cancers, when they're diagnosed, are localized. In other words, they're confined to the prostate. So what causes prostate cancer? How do men end up getting prostate cancer? Well, the very kind of disappointing answer is that we just don't know the exact cause. The most likely cause, as is the case with a lot of cancers, is changes related to genetic material. In other words, DNA that happens in cells. DNA changes can be passed down through families, can occur from the environment or certain lifestyle factors as well. But generally speaking, we don't know the exact cause. We do know that there are some risk factors for developing prostate cancer. So it's typically a cancer of older men. Of course, there's an exception to every rule, but the vast majority of cancers, prostate cancer, 75% are diagnosed in men who are 65 or older. We know that African American men have the highest incidence and death rates of prostate cancer, and we honestly do not know why this is. We know that family history also plays a role. So men who have a first-degree relative, so think father, brother, who has prostate cancer has a twofold risk of being diagnosed with prostate cancer himself. Things that have been extensively studied but do not have any conclusive data as far as risk factors are concerned are things like diet and supplements, and other things like inactivity, chemical exposures, and vasectomy. There's very little or no scientific evidence to suggest that these things cause prostate cancer. So can we prevent prostate cancer? Again, kind of another disappointing slide. Since we don't know the exact cause, it's not possible to prevent most of the cases. You know, we can't control our age, we're all going to get older, our race, and our family history. We have studied this, as a matter of fact. Are there things that we can do to prevent prostate cancer? So there have been 2 really big clinical trials that studied 2 medications for BPH, and that's just a fancy term for big prostate. Neither one of these trials showed that these medications should be used to prevent prostate cancer, so they're only approved by the FDA to help with urinary symptoms caused by big prostate. There have also been many big trials looking at things like fruit and vegetable intake and different vitamins and supplements, and the results of all of those trials did not show a decreased incidence of prostate cancer. So there are no nutritional supplements that are recommended for prevention. So what do we do? What I generally talk to my patients about is maintaining a healthy lifestyle. So a relatively balanced diet, regular routine exercise, don't use tobacco, and minimal alcohol. So even though the data is limited for prostate cancer prevention, doing these things can help promote overall health, which is also obviously very important. So screening for prostate cancer has been one of the most widely and hotly debated topics in medicine over the course of the past several years. So the great debate is, are we over-screening people? In other words, screening people that may not be appropriate for screening, leading to overdiagnosis, leading to overtreatment. So what exactly is screening? So screening is a test to find cancer or other diseases. Like I alluded to in my previous, it's been widely, hotly, and exhaustively debated over the course of several years. There have been many professional organizations that have issued their official statements for recommendations for screening, and honestly, the only consensus that anyone can kind of come up with is that men should be presented with the benefits of screening versus the risks of screening, kind of pros and cons. And I'll talk to you about why is this such a big deal? Why can't every single man just get a PSA blood test? And we'll talk about that. As an aside, the large clinical trial that was used to kind of catapult this debate into the mainstream is now being investigated as having a lot of faults. So some of these organizations who have come out against prostate cancer screening altogether might be changing their tune depending on the reanalysis of that clinical trial. So to screen for prostate cancer, men get a prostate exam. We call that a digital rectal exam. So that's when your provider inserts his or her finger into the bottom to feel the prostate gland. We can only feel the back part. The blood test called PSA, which is prostate-specific antigen. It's a protein that's made only by the prostate, and it secretes out into the bloodstream. We've had PSA screening around since the late 1980s. So the biggest part of the debate is that neither digital exam or PSA is 100% accurate. So if either one of those things or both are abnormal, that does not always mean that prostate cancer is present. And normal results don't always mean the absence of cancer. So that's where this gets a little bit complicated. There are other tools in development, so things like prostate MRI, which are appropriate for certain cases, but not for screening purposes, and other kind of fancy blood tests that are being studied to see if they could be used in lieu of or along with PSA. So as you can see from the screen, PSA can vary for a lot of different reasons. So just because men have a high PSA does not necessarily mean there's cancer. So things like infection or inflammation or just having a really big prostate, PSA does increase with age. Abnormal cells that aren't cancer, and of course prostate cancer. There are certain medications that can lower PSA, and of course prostate cancer treatment does that too. So when I see a man in my clinic for an elevated PSA consultation, this is usually a 20 to 30 minute discussion because there's a lot of things to talk about, there's a lot of things to check, and we have to make a decision together and use shared decision making to talk about whether or not to pursue a biopsy, which is taking pieces of the prostate based on an elevated PSA number. So I always joke that all my patients look like this when they come in to see me, that everyone is nice and fit, healthy, and that's not always the case. Sometimes people are really sick, and we have to be mindful about pursuing things like biopsies if folks are really sick. The vast majority of patients with elevated PSA usually have no symptoms. Prostate cancer in general usually doesn't have symptoms unless it's much more advanced. When men come in with urinary symptoms, a lot of times it's because they have big prostates and not necessarily because of cancer. Men who have kind of late stage or advanced stage prostate cancers can come in with bone pain, kidney failure, things like spinal cord compression. These things are not very common. So how do we diagnose prostate cancer? So shared decision making to screen. So I can't kind of push that take-home point home enough that it's really important that men and providers decide, number one, whether or not to screen, and number two, whether or not to pursue diagnostic tools. So a prostate biopsy takes pieces of the prostate. So this is generally done in the office with patients are awake. Sometimes we do put men, give men anesthesia medicine if for some reason they're unable to tolerate the exam, because we certainly never want to cause anyone any pain or discomfort. So generally we take 12 pieces of the prostate, and there's a probe that goes up through the bottom. So we don't cut on people, it all goes through the bottom. And we use an ultrasound to see what we're doing. And then we take about 12 pieces of the prostate from different parts. We use kind of a standard template. There's a minor prep, so things like stopping blood thinners and taking an antibiotic pill and doing an enema in the morning. So we take those pieces and then we send them off to the pathologist. So a pathologist is someone who looks at something under the microscope and tells us what it is. It usually takes generally about a week for us to get those results back. So once a diagnosis of prostate cancer is made, how do we determine whether or not it's aggressive looking or a slow growing prostate cancer? So what the pathologist does is they look at the slides underneath the microscope. If they see prostate cancer cells, they assign it a grade. So they look at it and they'll say, what's the most abundant prostate cancer cell under in this particular slide, and they give it a number. And then they say, what's the second most abundant cell on this slide, and they give that a number. And we add those numbers together to get what's called the Gleason score. So the best Gleason score that one could have, meaning the least aggressive, is a Gleason score of 10. The most aggressive Gleason score, the least aggressive is 6, and the most aggressive is 10, with 7, 8, and 9 kind of being in between. So how do we stage prostate cancer? So staging means seeing how aggressive or how advanced a cancer is. So that all depends on a lot of variables. Most prostate cancers don't require any further workup after a biopsy, but if they have certain characteristics like a high Gleason score or a high PSA, then providers will do things like get CT scans, which is a very fancy X-ray to look inside the body, and a bone scan, and that takes a picture of the entire skeleton to ensure that there's no cancer spots in the bones. So this is an unfortunately very blurry picture of a CT scan and a very blurry picture of a bone scan. I'm sorry that those didn't exactly transmit the way that I wanted them to. And so this is a table that shows the different stages of prostate cancer, and you can see they each have a lot of variables. So depending on how the prostate feels, what the PSA is, and how the cells look underneath the microscope. And staging prostate cancer helps us in determining how we treat it. So how do we treat prostate cancer? So I'm first going to talk about localized prostate cancer, which means that we don't see any prostate cancer outside of the prostate that's gone to faraway places in the body. So the first treatment I'd like to talk about, and I'm sorry I keep pushing up my glasses, I should this morning, is something that's called active surveillance. So sometimes it's really hard to talk about not treating a cancer, but there are men who, based on things like their PSA and if they have a low volume prostate cancer, in other words, 2 or 3 or 4 biopsy pieces that were positive, if they have a 10-year life expectancy, then sometimes active surveillance is the way to go. So what we do for these men is we see them in clinic every 3 to 6 months for a PSA test, a prostate exam, and then we re-biopsy every 1 to 2 years. So all of these things can change depending on several things. So if there is a crazy change in the PSA where it jumped really high, then we would consider moving up a biopsy. or if a patient decided that he did not want to do active surveillance anymore for whatever reason, then we would rebiopsy to see kind of where things stand to further direct his treatment. So this is not an appropriate intervention for all men, even if they meet every single one of our criteria. Sometimes it's, like I said, it's hard for people to wrap their brain around not doing anything for their cancer, and that's very understandable. But we would only recommend this for men after surveillance if they have a very low risk or low risk type of prostate cancer. So getting into more kind of definitive treatments for localized or early stage prostate cancer, radical prostatectomy is surgery where we take out the prostate gland, the whole gland, and the seminal vesicles. So back in the day, these surgeries were done open, men had big scars, longer hospital stays, but nowadays we have much more precise technology such as laparoscopic surgery where we use several small incisions to insert ports to take out the prostate. And also we're using robotic technology, which is also very fascinating. That helps with better visualization so the surgeon can see better, and it's more precise. So things we take into consideration for men who would like to have their prostates removed are things like age, other health problems. So in other words, if men have really bad lung disease or really bad heart disease and it would be dangerous for them to have surgery, then we wouldn't recommend that. And also for men who've had prior belly surgeries, because sometimes that they can have a lot of adhesions and it can make another surgery in that area much more complicated. Generally speaking, men stay one night in the hospital, leave with a catheter in the bladder to help things heal in there, and then come back about a week or 10 days later to the clinic to go over pathology and have their catheter removed. Follow-up is every 3 months for the first year, every 6 months until year 5, then annually until year 10. And this is a picture of a robot. It's the surgeon sitting at the robot here looking in, and there's an arm that comes over to where the patient is that the surgeon is controlling from the robot station. Radiation therapy is another treatment for prostate cancer that's an early stage. Radiation therapy has also that more precise, leaving men with fewer specks and fewer kind of radiation that touches other parts of the body. So radiation uses a machine outside the body to deliver radiation, usually for 5 days a week, so Monday through Friday for 4 to 6 weeks. Depending on the stage of the cancer, men will get hormone shots, but that's usually if it's an intermediate or high risk type of prostate cancer. Another treatment is called brachytherapy, which is a type of radiation therapy, but it's done with these tiny little radioactive seeds that are implanted into the prostate. This is generally reserved for men who have low-risk disease, and prostate size does matter. So men with very, very big prostates, it's not recommended for them because it's much more difficult. Cryotherapy is surgical freezing of the prostate, and HIFU ablates the tissue using heat. So these two treatments have not been around as long as prostate surgery and prostate radiation and don't have kind of the same amount of robust data that backs them up. So we don't do a lot of this and we don't see a lot of this, but that doesn't mean that it wouldn't be the right treatment for men who meet certain criteria. So what happens after treatment? So you have surgery, you're done with your radiation, you're done with your cryotherapy. What happens after that? Typically, for the most part, we like for men to come back to clinic every 3 months for the first year, and then every 6 months until year 5, and then once a year after that. What do we do at these visits? So we check a PSA blood test, and after surgery it should be 0, and after radiation it should be very low. We do things for side effect management and treatment of any side effects from these treatments, and we'll go over that in later slides. The two main things being sexual dysfunction and leakage of urine. We should be talking about emotional well-being. It's something that we're not always really good at, but that we should address because a lot of times men are living with uncertainty related to their cancer diagnosis and treatment and potential side effects. Promotion of healthy lifestyle, so making sure folks have primary care providers and are getting other cancer screenings, diet, exercise, and avoiding harmful substances, and referrals to specialists as needed. So sometimes cancer can come back even after it's been treated with surgery or radiation or one of the other treatments I mentioned. But thankfully, many times it's still very curable. There's certain characteristics that put patients at a higher risk for cancer to come back, and I've listed those there. It's usually more aggressive looking tumors or higher PSAs and characteristics like that. So I'm going to go into advanced prostate cancer now and talk about kind of the plethora of treatments for advanced prostate cancer, which I've defined for you as prostate cancer that comes back after definitive therapy, locally recurrent disease, systemic recurrence, which means disease outside of the prostate, or clinical recurrence. In other words, men are having symptoms of cancer that come back. So types of recurrence. So biochemical means that we can see PSA and there are definitions of, what exactly does that mean to then prompt additional treatment. Local means it's come back within the prostate itself, and distant means it's come back in other organs. So things like lymph nodes, bones, sometimes organs like liver and even lung. So what can we do? So salvage treatment means giving treatment after you've already had treatment to hopefully get rid of the cancer for good. So after radiation, prostate surgery to remove the prostate that's left, that is extraordinarily difficult technically. It's not done very often because it has high morbidity. In other words, a lot of potential consequences and side effects from doing that. Hormone shots, which we'll talk about, and surveillance. And after surgery, radiation to where the prostate used to be, hormone shots, or surveillance. So if we transition men at any time to hormone treatment, which I'll talk about, when do we give it for patients with advanced prostate cancer? So if men don't have tumors that we can see on a CT scan or bone scan, then we can delay it for a little bit and follow the PSA. If men have distant tumors that we can see on CT scan and bone scan, then generally we start these hormone treatments sooner rather than later. So a key point is that prostate cancer tumors, especially these advanced tumors, require testosterone in order to grow. And testosterone is one of the predominant male hormones. So the hormone treatment that I'm talking about gets rid of about 90% of the testosterone production. So what are these hormone shots? So the other thing that we call them are androgen deprivation therapy, or ADT, which is not the security company. I get that a lot. And there are two ways that we can accomplish this. The first is surgical castration. So castration means removing both of the testicles. As you may imagine, this is not a very popular choice. Number one, because it's permanent. And number two, because men can have significant body image issues with the loss of both of their testicles. Medical castration is giving men medicine to make the testosterone very low, and this comes in a variety of different forms. We have shots, also called injections, so they can be given in the bottom through the muscle. They can be given in the belly. There's also implants that can be put into the arm that last for a year. And depending on several factors, the healthcare provider that you see for this will decide which is the best treatment. So potential side effects of these hormone treatments, it's basically like menopause is what I tell folks. So you're losing this big percentage of hormones. So things like hot flashes, feeling tired, fluctuating mood, weight gain. Some men will have enlarging tissue in their breast area, thinning of the bones, and sexual dysfunction, and that's just to name a few. So sometimes, unfortunately, men come to us and they already have prostate cancer that's gotten outside of the prostate. So when men are diagnosed and they already have bad cancer, so metastatic is just a fancy word for cancer that's gotten outside of its original site. The men who come in and they're metastatic, what can we do for them? it's, this is never an easy conversation to have with folks because we can't cure this, but we can treat it. So we have relatively new and really exciting science and research that's been done in the past couple of years that's shown that for these men, in addition to the hormone shots that I talked about, I'm going to say hormone shots a lot because that's mainly what I do. But in addition to the hormone therapy, we can give chemotherapy, or the late breaking news out of a recent conference within the past couple months are special pills that these men can get. And these research trials have shown significant extension of life for these men who are getting these treatments. So this was a really exciting research finding for us. So for men who have advanced prostate cancer and go on to hormone therapy, in general, the cancer responds to that for an average of 2 to 3 years. And again, this is an average. Some men go many years with hormone therapy alone. And then the PSA starts to go up. So then what do we do? Because if we're doing hormone therapy, generally speaking, the PSA should stay low. But eventually the cancer outsmarts us. So what do we do? How do we help? So we call this phase or stage of prostate cancer castrate resistant. So what does that mean? That means that the PSA blood test is going up, but the testosterone remains very, very low. So we always keep the hormone shots or hormone treatment. We never take that away. So what I tell my patients is that the hormone therapy serves as kind of the base of the pyramid, and then we build upon the pyramid depending on how their cancer responds. So if you think about it, if you take away the base of a pyramid, the whole thing crumbles, and we certainly don't want to do that. So we always keep the base. We get imaging studies, which are fancy x-rays prior to starting any new treatment, so that we have a new baseline and kind of know what we're working with. So there's this very rare category of men who are on hormone therapy and their PSA starts to rise, but their testosterone is really low, and we do scans and we don't see anything. In other words, no big swollen lymph nodes and no spots in the bones. So this category is called non-metastatic castrate resistant. I don't have a lot of patients who meet this, who are in this category, because it's not very common. So the treatment options for them include additional pills that block more of the hormone production. So metastatic castrate-resistant disease means that the PSA is going up, the testosterone is very low, but that unfortunately we can see evidence of tumors when we do CT scans and bone scans. The most common places we see these tumors are in lymph nodes and in bones. So what do we do? When I started doing this roughly 7.5 years ago, we only had, I think, only 2 treatments in addition to the hormone therapy for men in this category. We didn't have a lot to offer, and men, unfortunately, were passing away from this disease really early on in their treatment. Since I've been doing this, there have been at least 5 new treatments that have been scientifically proven to help with this stage of the disease and have been approved by the FDA. So while we don't yet have a cure for men who have prostate cancer outside of the prostate or metastatic disease, we do have more treatments to offer them, which in turn are helping men live a lot longer than before these treatments were discovered. So chemotherapy, we have 2 types of chemotherapy. So you've probably heard of chemotherapy. That's generally speaking, you go to an infusion center and get an IV put in, and it drips through a bag into the vein and works to attack the cancer cells. There are generally speaking, 2 types of chemotherapy that are approved for men with metastatic prostate cancer. Their fancy names are docetaxel and cabazitaxel, and they're given every 3 weeks through an IV, and we try and give men at least 10 rounds of these chemotherapies if they can tolerate them. We also have pills that men can take now. One is called abiraterone and one is called enzalutamide. And they work with different pathways to help block additional testosterone production from the testicles and from glands that sit on top of the kidneys called adrenal glands, and also the tumor itself. These pills, thankfully, are generally very well tolerated. We also have an immunotherapy that was approved for prostate cancer. So basically, immunotherapy works to stimulate an immune response and stimulate the immune system to fight the cancer cells. Sipuleucel T is the immunotherapy that's approved for prostate cancer. We also have a treatment that's called radiotherapy. It's called radium-223, and it's an alpha particle that gets injected into a vein. It takes about 5 minutes or so, and it latches onto spots in the bones where there are cancer cells to help form complexes in the bones, and it helps with bone pain. So there's all these treatments. When do we change them? So we have to take into account several things. The PSA, the testosterone, how patients are doing clinically. In other words, are they having any symptoms from the cancer itself, and what scans look like. So are there any new spots on x-rays that we do? So generally after chemotherapy, we just kind of wait and see how the PSA responds. On the pills that I mentioned, we look for a consistent rise in the PSA as well as new tumors on scans. One of the most frustrating parts about all of this is that there's no set algorithm for when to use which treatment. So it's a lot of it is based on provider preference and side effect profile and patient preference as well. So there's no magic formula. It's not a one-size-fits-all. So during treatment for more advanced prostate cancers, these visits are relatively frequent depending on treatment. We get a bunch of blood work to make sure that the treatment we're giving is not hurting you on your insides and your kidneys or liver, side effect management, emotional support, and unfortunately we do have to have difficult discussions when cancer progresses or when patients don't have any additional treatment options, and we have to talk about things like hospice. So this is a very busy slide that I'm not going to go through, but it just shows that there are lots of treatments depending on the stage of prostate cancer. So for supportive care, for men with advanced prostate cancer, we think about things like bone health, because the hormone shots can over time cause bone thinning. So calcium and vitamin D supplement is very important. There are some fancier prescription medicines that can be given as appropriate. If men who still have their prostates have urinary symptoms, we can radiate the prostate. We can do surgery to kind of chip away at the big parts of the prostate. We don't like to do this, but sometimes if the symptoms are bad enough, we have to insert a tube into the bladder to drain the urine. If men have bone pain from bone spots, then we do things like pain medicines, which come in a bunch of different forms, radiation to help with pain, and also surgery if there is ever a fracture. So unfortunately, there's no cure for metastatic prostate cancer. In other words, we don't have anything to make this go away. It's always very important for your healthcare providers to be incorporating best supportive care. In other words, helping you with side effect management and also emotional support as well. Just because we have multiple treatment options doesn't mean that they all have to be used. In other words, there's not a rule that says that you have to take all these treatments. It's always important for patients and their caregivers to feel that they can be open and honest with their providers about stopping treatment if they feel like that they're unable to tolerate things. So survivorship. My favorite kind of definition of cancer survivor is from the time of diagnosis until the end of life. Prostate cancer patients have very unique needs when it comes to some survivorship issues that I'd like to go through. So side effect management in particular. So erectile dysfunction means the inability to get or keep an erection that is good enough to have a sexual encounter. This can happen after all of the treatments for local prostate cancer and certainly with the treatments for advanced prostate cancer as well. There's a variety of reasons for that. So with surgery and radiation, it's kind of a direct blow to the nerves that help with an erection because they wrap around the back part of the prostate. And with more advanced treatments, not having a lot of testosterone can also contribute to erectile dysfunction. Thankfully, there are a lot of treatment options. So there's something called a VED, which is basically a fancy penis pump. There are several pills that can help with erections. There's a little suppository that can be put in the urethra, so it goes through the tube where the pee comes out. There are penile injections, so giving a shot into the penis, which every time I talk to this for the first time about a patient, they usually turn green, and I'm afraid they're going to fall on the floor. However, it's a very effective treatment for erectile dysfunction. And then kind of the most extreme option would be to have a surgery put in, a penile prosthetic. This is actually also a very effective treatment and should be discussed with a urologist. So this is just a picture of a penis pump. It goes into the plastic there, and basically it helps to pull blood into the penis to help with length and with strength. These are the medications that are approved to help with erectile dysfunction. I'm sure you've seen some of these before. This is a picture of that little suppository. I personally don't prescribe this a whole lot, number one, because it's pretty darn expensive, and number two, a lot of folks use some and a burning penis is a good thing. So this is a picture of how my patients respond when I talk to them about shots in the penis, which I understand. But generally speaking, the needle for these penile shots is very small, very easy to do, and it's usually quite effective. And here's a picture of how it's done. This is a picture of one of the options for penile prosthesis, or a pump that goes into the penis, surgery for that. And then this is kind of a list, I'm not going to go through all this, of the pros and cons of each of these treatments. It's certainly not a one-size-fits-all. Sometimes it takes multiple tries with different treatments to figure out which one is best. So urinary incontinence is leaking of urine. Why this happens is because there can be muscle or nerve damage to the urinary sphincter, which helps keep the urine in the bladder. Sometimes men have to wear pads or pull on briefs. What we try to teach folks before their treatment is to do these things called Kegel exercises, which are simple pelvic floor exercises. If the urinary leakage is severe or doesn't get better with time or is a significant quality of life issue for men, I like to refer them to physical therapy. There are physical therapists who specialize in management of urinary leakage, and they can come up with an individualized physical therapy pelvic floor health program for men. If the urine leakage is severe or refractory, in other words, we do conservative things to help it, and it doesn't get better or doesn't go away, then there is a surgical option for men who would consider that. And it's called an artificial urinary sphincter, and this is just a little picture of it there. Hot flashes. Hot flashes, hot flashes, hot flashes happen in the vast majority of men who are hormone shots. Unfortunately, we don't have a lot of good treatments for hot flashes as far as medical management goes. So there are a couple pills that we can try, but generally they just don't work that great. So a lot of times what I try and teach folks is to wear loose cotton clothing and dress in layers, so you can take stuff off, like a sweatshirt if you get one of these hot flashes. Fans, ice. I had a patient teach me once that he keeps an ice pack under his pillow at night, and if he wakes up with a hot flash, which is common to happen at nighttime, he flips over his pillow and it's nice and cold and he gets good relief. My patients teach me things all the time, and I think that's a really good point of advice. Sometimes things like alcohol and caffeine and spicy foods can make hot flashes worse, so if men notice that those are triggers, I tell them to try and avoid them if they can. And just trying to keep as cool as possible. Most men don't require treatment or aren't interested in taking a medication, because some people are already taking a lot of medications, and that's understandable. So sometimes these lifestyle changes are enough to make a difference. So we've already touched on erectile dysfunction, but there are other types of sexual dysfunction that men with prostate cancer may experience that can be a significant quality of life issue. So a lot of men on these hormone shots find that their sex drive is just not what it used to be. Libido, which is a fancy word for sex drive, is really dependent on high levels of testosterone. Unfortunately, on hormone therapy, we can't give folks testosterone replacement because that totally negates what we're doing. So this is a really, really hard thing to treat. Sometimes men find that they have shrinkage of their penis. On hormone shots, that's because of the low testosterone, and after surgery, it can be because the muscle tone is just not challenged. The vacuum pump, the vacuum erection device, can actually sometimes help with this. Sometimes men use it for rehab purposes, so using it once a day just to kind of remind the blood where to go. So fatigue affects the vast majority of people with any kind of cancer. There's a lot of data to suggest that exercise is one of the most effective treatments for helping with fatigue. This is hard to kind of get people revved up for, because a lot of people are too tired to exercise. I tell my folks, you certainly do not have to run a marathon. That would make me a hypocrite. But just a simple, walk down the street, it can even be 10 minutes or so, can help and work their way up. Sleep hygiene is also important, so things like going to bed at the same time every night, avoiding things with bright lights before you go to sleep, comfortable room temperature, don't do anything in the bed except for sleep and sex, accepting assistance from others to get some of your day-to-day tasks off your plate, energy conservation, so resting when your body tells you that you need to. And we as your healthcare providers should be checking for other causes. So sometimes it has nothing to do with the cancer, or not everything to do with the cancer. So checking blood work to make sure there's not something else going on that can be contributing to this. Emotional support is crucial for men and their caregivers on any kind of spectrum during prostate cancer treatment, whether it is at first time at diagnosis, men who are on surveillance, men who get surgery or radiation, and men who have more advanced disease. Emotional support is crucial. So patients should feel like they can maintain an open and thoughtful discussion between their providers, and also patients and their caregivers, particularly their spouse or partner. Sometimes talking to other men can be really helpful. I've had many patients who talk to men in their community or their church or their workplace and kind of form their own little unofficial support groups, and they found that to be very helpful. There are studies that show that many prostate cancer patients report feelings of depression and anxiety, and these things should not be ignored. Can be for many reasons. There's a lot of uncertainty that comes along with the cancer diagnosis. The diagnosis itself can trigger these types of feelings, side effects of treatment, other things that are, we don't talk about a whole lot, financial, missing time off work, insurance concerns, and guilt about change in sexual. It's not an all-inclusive list, but those are a lot of things that my folks will talk to me about. We should always take the well-being of our caregivers into consideration. A lot of times we spend most of the visits focusing on the patients, and we should absolutely be giving the patients our undivided attention, but not leaving out the caregivers. And this can be spouses, partners, other family members, friends, anyone who is involved in kind of the primary caretaking of prostate cancer patients. So a lot of caregivers find it really meaningful and enriching to be able to care for someone during a time like this. It's really important for caregivers to recognize their own needs. There have been papers that show that caregivers report a ton of emotions, a lot of positive emotions, but sometimes some emotions that we shouldn't overlook, things like sadness and feeling overwhelmed. Self-care is crucial for caregivers. So taking care of the self makes it that much more enriching to take care of someone else. And I've listed some things there that can really help. Asking for and accepting help from others can sometimes be very hard to do, but it can take a lot off your plate. And honestly, folks really want to help. A lot of times friends and family members, coworkers feel a little helpless when someone they care about is diagnosed with cancer, and any little thing they can do to help, I know that a lot of people do. Seeking help from a mental health professional. This goes for patients experiencing these feelings and caregivers. And there's also caregiver support groups, whether that's online or somewhere in person close to you. So prostate cancer in general is really complicated. It's really complex, and it takes a village. Along the way, you might run into people from any of these categories. So certainly nurses, advanced practice providers, which is what I am, a nurse practitioner, all kinds of different types of physicians, mental health providers, pharmacists, recovery team for things like physical therapy, nutrition, and then ancillary staff who a lot of times we don't see, but they're doing a lot of the behind the scenes work. So teamwork is really important in taking care of patients and caregivers with prostate cancer, so that they can get the best possible care. So just a couple of pearls. So prostate cancer is very, very common, and the vast majority of prostate cancers upon diagnosis are localized, treatable, and curable. While there's no known prevention, good self-care is important for overall health. Unfortunately, in stage or metastatic disease, we don't have a cure yet, but thankfully men are living longer thanks to newer treatments. Supportive care is crucial throughout the continuum. So from during treatment, after treatment, during treatment for advanced stage, and when we have to have difficult conversations for men who will die from their disease, talking about things like end-of-life care and hospice care are really important as well. Reach out to your treatment team. You know, we're here for you. We want to hear from you. There are absolutely no such thing as a silly question, and it's important to know that you're not alone throughout all of this. So who can help? Your treatment team, resources at your institution, so it depends on what your needs are, but here at UNC we've got folks like counselors and pharmacy assistants, support groups, local and regional support. So there are inpatient support groups, there are online support groups, which has become a much bigger thing in the area of in the kind of time of internet all over the place, but a lot of men and caregivers find a lot of help from online support groups, and then national organizations who specialize in supporting men and their caregivers who have prostate cancer. So this is just a short list of resources for patients and caregivers, but a lot of times on these websites there's information for healthcare providers, and there's also information in easy to understand layman's terms for patients and really anyone who's interested in learning more about prostate cancer. So I want to thank you for your time. It's a pleasure to be able to talk to you about prostate cancer. I know that it's a lot of information in a short amount of time. We could probably talk about each of these subcategories for at least an hour. So I hope I was able to provide some insight for you on kind of prostate cancer 101, and I sincerely appreciate you taking the time out of your day to join us.
Mary, thank you so much. That was a wealth of information about prostate cancer. I want to encourage our listeners right now to go ahead and, if you haven't already texted questions in, to go ahead and do that. And let me just remind our audience how you would go about that. If you already joined the Poll Everywhere poll, then all you have is text in the question you have. This is anonymous, and we'll go ahead and those we receive those. If you didn't join earlier, you'll text the letters UNCCN to the number 333 one time. You'll get a response back that you've joined, and then you can go ahead and text in those. You can also go to the website, which is pollev.com/UNCCN, and then you'll see where you can go ahead and just type in those questions there as well. I have a few that I'll get. We'll start with while we're waiting for our audience to go ahead and share their questions. We hear a lot about immunotherapy. In fact, we had a presentation on immunotherapy earlier this week. What is the relationship of immunotherapy to prostate cancer treatment?
Yeah, so at this time we have one immunotherapy that's FDA approved. So it's called Provenge. It's FDA approved at least 5 years ago at this point. But the way that it helps patients is they have to go to the Red Cross and they have to have kind of this fancy taking out of their cells. It's sent to the company who then mixes it in a formula, and then it's infused back into the patients. So it's interesting because we sometimes have a hard time knowing whether or not it's working, because an immune response is kind of invisible, and it doesn't affect the PSA because it doesn't work on the hormone pathway. So it'll be interesting to see if in due time we get more types of immunotherapy for advanced prostate cancer.
Okay, but we just don't have the research back at this point to know about the efficacy of that. All right, still waiting for questions. Again, if you have one, and you can just go ahead and share that via poll everywhere, either texting on your phone or at the website there. It seems like what strikes me about all the information you've been presented today is that the decision making must be extremely difficult for a patient, and I don't get the sense that there's necessarily just a flow chart. If this, then this, then this, that you can just follow and say, okay, these are the particular test results, et cetera. But rather, I've got to believe the decision making is excruciating around this. What are some of the, and I know you've referred to some already, but what are some of the best ways for a patient to figure out his own personal path and then to validate those decisions?
Right, that's a great question. So, what we do in this decision-making process, so if I could give you an example. So let's say a man has early stage prostate cancer and he is eligible to go on active surveillance or have surgery or have radiation. So imagine being a patient and having us say, here are your choices, which one would you like? So a lot of times these decisions are made after really thoughtful discussions with patients about potential side effects. Sometimes people just don't want to have surgery. Surgery can be very frightening for folks. Sometimes they find radiation just to be a little bit too labor intensive because they have to come so many days in a row. But one of the take-home points we tell folks is that we don't have a clinical trial that has compared surgery and radiation to where we can say one is better than the other. So there is no best treatment. So it really kind of boils down to just thoughtful discussion and giving patients time to figure out what they think would be best for them, involving their caregivers as well. It can be really tricky and frustrating.
I'll bet. I'll bet. Well, thank you for that advice. Great talk. Thank you so much. One of our audience members says. Another one says, I was a participant in a clinical trial with finasteride, thank you, as a prostate cancer preventative. The trial ended early because it was determined that people with, and I apologize, we have a limit on how many letters we can get in your question. So if our guest will go ahead and text us the rest of that question, then, and I don't know if you want to take a guess at that.
I can maybe speculate. So, there was a big clinical trial studying finasteride, which is the medication used to treat big prostate, or BPH. That trial ultimately did not find in kind of the end result that it could be suggested to use in prostate cancer prevention. Because of that trial, the medication carries a black box warning, because men who then had biopsies and had been on finasteride, there was not an insignificant number of them that were found to have intermediate risk prostate cancer. So we don't think that the drug causes prostate cancer, and that makes it really clear when it's being prescribed. We think that the prostate just gets smaller with medicine, so we have a smaller surface area to biopsy. So in other words, a higher likelihood of finding cancer. So we don't think that it causes prostate cancer. I hope that was helpful.
All right. Thank you. And we are nearing 1 o'clock, so I'm going to wrap up with just a few things. We want to, of course, thank you. We're
You're
so
welcome.
glad that you were here today.
Thanks for having me.
We want to thank the University Cancer Research Fund, the generous support of that by the North Carolina General Assembly and the UNC Lineberger Comprehensive Cancer Center, excuse me. We want to thank our team, Mary King, Veneranda Obure, Alan Brown, for all the hard work that they do to make this lecture and every lecture possible. Next Community Lunch and Learn lecture, What People Struggling with Cancer Want to Know, with Melissa Holt. So we hope that you'll be here for that. We hope that you'll visit us on the web. You'll find links to all sorts of things at unccn.org, including all of our upcoming events, conferences, and then we also have a lecture library with over 180 different lectures there. It's fully searchable down to every word of every PowerPoint slide. So if you have topics that you'd like to find out more about, certainly encourage you to go there and look at some of our lectures. We hope that you'll, if you found this lecture informative and know somebody who you think would benefit from this or other lectures, we certainly hope that you'll share that. We have a newsletter, and you can just email us at unccn@unc.edu and let us know that you'd like to receive our monthly free newsletter that has information about all of our events as well as articles of interest that come up month to month. All right, we're on Facebook, Twitter, YouTube, so we hope we'll see you in one of those places. Thank you, and have a great afternoon. Thanks so much. We'll see you next time.